again. It's a pleasure to be able to share with you the findings of the AQUARIUS study. This slide summarises my disclosures, and I would start by saying AQUARIUS is an intravascular ultrasound imaging study of disease progression with a surprising twist. So there were two fundamental questions that we really embedded within AQUARIUS. The first was that there continues to be a lack of consensus with regards to what's the ideal blood pressure goal for patients with established coronary disease. Most of our guidelines tell us to treat patients to 140/90, but we really don't know if that's the ideal blood pressure. And while there has been small studies performed in patients with blood pressures, particularly between 130 and 140, the evidence is still yet unclear. So there continues to be a question in clinical practice about what's the ideal way to manage our patients' blood pressure with coronary disease. The second is that we're interested in the concept of could we inhibit renin activity, and would that have a favourable effect on coronary atherosclerosis? And that's based on preclinical data suggesting that the renin-angiotensin aldosterone system has an important role in the progression of atherosclerosis, and that renin inhibition in preclinical models has an anti-atherosclerotic effect. So we progressed to perform AQUARIUS. This is an intravascular ultrasound study of 613 patients with symptomatic coronary disease. Their blood pressures were essentially within the pre-hypertensive range. Systolic blood pressure between 125 and 139 millimetres of mercury, diastolic blood pressures less than 90 millimetres of mercury, and 2 additional cardiovascular risk factors. We essentially treated patients with Aliskiren 300 milligrams or placebo for 24 months, intravascular ultrasound at the start and at the completion of the study. Blood pressures at baseline were a median of 132 millimetres of mercury systolic, 77 millimetres of mercury diastolic. You see here the on-treatment levels of blood pressure. We saw favourably lower levels of blood pressure, both systolic and diastolic, in the Aliskiren group. The magnitude of difference between the groups was clearly predictable given where the blood pressure started. And again, predictably, the renin inhibitor resulted in a significantly lower renin activity and a compensatory increase in plasma renin concentration. Now, the primary endpoint of the study was change in percent atheroma volume. We observed a reduction in that parameter in the Aliskiren group by 0.33, the p-value compared to baseline 0.09, a strong trend to regression, which just failed to meet the conventional definition for statistical significance. The difference between the groups, again, a p-value of 0.08, again, a strong trend for a difference between the groups, not statistically significant by conventional standards. We observe a very similar observation with the secondary endpoint, the change in total atheroma volume. This time we see a statistically significant reduction in that parameter in the Aliskiren group. The p-value for the comparison between placebo and Aliskiren, 0.18. We did collect and essentially adjudicate cardiovascular events in this study. This was a study that was not powered to look at cardiovascular events, so we were quite surprised and quite pleased to see, in fact, that there was a numerically lower number of cardiovascular events in the Aliskiren group. There was, in fact, 26 major adverse cardiovascular events with Aliskiren, 50 with placebo, and unlike many of our imaging studies previously where differences in clinical events are often simply just due to revascularisation, we see significant differences here in terms of myocardial infarction and a strong trend towards less mortality in this group. It is important to specify that this is a pre-specified exploratory endpoint. These are small numbers, but we certainly find that these are quite intriguing and provocative findings in the context of a small imaging study. When we looked at safety, we saw that the Aliskiren group was more likely to have discontinuations due to adverse events, more hypotension. Intriguingly, no differences in hyperkalemia, no differences in terms of creatinine elevations above the upper limit of normal, and was generally well tolerated by all patients. So in conclusion, we're going to conclude that this overall is a neutral study, yet there are some provocatively and potentially positive findings within it. Aliskiren 300 milligrams resulted in lower blood pressure and renin activity compared with placebo. For the primary endpoint, a trend to regression was observed with Aliskiren, although this did not reach statistical significance. However, we did observe fewer cardiovascular events in the Aliskiren group, and it tells us that we continue to tell a story that there may be benefits from continuing to be more aggressive with blood pressure lowering in patients with coronary disease, we need to do a large definitive outcome study to ultimately tell us what the ideal blood pressure for our patients is with coronary disease. Thank you.
Thank you. We'll open for questions. Thank you.
Hi, I'm Peggy Peck. I'm with MedPage today. So I'm curious about the clinical events. And are you speculating here that a possible explanation would have more to do with the aggressive blood lowering than the specific agent, which of course has had a somewhat checkered history since it came to market?
Yeah, so there's a couple of questions embedded within that I'll try to tackle. When you look at the disease progression itself, we don't see a direct relationship between achieved or changing levels of blood pressure. The blood pressure changes are relatively small, but they are there, and disease progression. We have not done the analysis to look at the clinical event versus blood pressure analysis yet, so I think that will be intriguing. This was quite a provocative test to do in the first place, the concept that a renin inhibitor might be anti-atherosclerotic. When you think about all of the approaches that we've been trying to get regression of atherosclerosis, many of which don't work, I thought this was a long shot from comparative perspective, but there is good data to suggest that renin inhibition may have effects above and beyond its ability to lower blood pressure, anti-inflammatory, antioxidant. We don't know what might have underlied all of this. And the final point I'd make is that we see here less clinical events in association with a strong trend towards less progression of disease. And I think it very much kind of complements what we've reported and a number of times, this concept that disease progression associating with less events, and perhaps that does kind of contribute to that. And then the final comment I'd make is the reference to the checkered history of the compound. During the course of this study, we were required to prematurely discontinue a number of diabetic patients from this study on the basis of the premature termination of the Altitude trial, in which there was a potential adverse effect in high-risk type 2 diabetic patients. We're going to present here this morning subgroup analysis, which again is post hoc and exploratory at best, but it does suggest that Aliskiren regresses plaque in patients without diabetes, and in the diabetic patients there was no benefit whatsoever. And so perhaps there are differences according to how high risk they are, and maybe for Aliskiren the sweet spot is not the ultra high risk patients. Unfortunately, they're the patients that have largely been enrolled in all of the Aliskiren studies. Perhaps the benefit more is patients with more moderate risk.
Other questions? All right, thank you.